Clinical chemistry, renal disorders, pathophysiology, and diagnostic correlation. The renal system contains four basic components: the kidneys, the ureter, which transport urine from the kidneys to the urinary bladder, the urinary bladder, and then the urethra, which transports urine from the urinary bladder to the outside of the body. In men, the urethra is longer than it is in women, and that plays an important role in some of the clinical features of different types of infections and also the ability to pass certain stones. 6 primary functions of the renal system include urine formation, the regulation of fluid and electrolyte balance, the regulation of acid-base balance, excretion of waste products, protein conservation, and hormonal function. So what happens inside of the kidneys have a small component called the nephron tubules, or the nephron system. So basically, substances are going to leak out of the bloodstream, so they leak out of circulation into these nephron tubules. It's the nephron tubules' job to suck back up the stuff that the body still needs. So that's called the process of reabsorption. So it's not absorption, because absorption happens in the digestive tract, primarily in the small intestine. It's reabsorption because the nutrients were already absorbed once, they're floating around in the bloodstream, and everything falls out of the bloodstream into those nephrons in the kidneys, and it's the nephron's job to suck back up or reabsorb the substances that are still needed in the body. So most of our glucose is reabsorbed. Unless a patient has diabetes or some type of kidney disorder, most of the glucose is sucked back up in the body. Same thing as proteins. So a lot of times proteins are too large to actually get into the nephrons, but if the proteins or amino acids get into the nephrons, they're typically reabsorbed because we want to keep those things in the body. Anything that's left inside of the nephrons is considered waste, and that waste is then going to travel from the nephrons into the collecting duct, which then dumps into the renal pelvis and into the ureter. And the ureter is going to carry that down to the urinary bladder, and the urinary bladder is going to store urine for a period of time until it's convenient for us to urinate. And then the process of urination is typically under voluntary control. So we decide when it's appropriate to urinate, and we can control the sphincters that regulate urination. The regulation of fluid and electrolyte balance. So if we sense that we need to have more fluids inside of our bloodstream, the kidneys, those nephron tubules, are going to reabsorb more liquid. If we have too much water in our system, the kidneys and those tubules are going to allow a lot of the water to just pass out through the nephron tubules and into that renal pelvis and eventually into our urinary bladder. Electrolytes. So if we have too much sodium in the body, then our nephrons are going to allow more sodium to be lost in the urine. If we don't have enough sodium, our nephrons are going to reabsorb more sodium. And that's the primary way that they regulate all of these things. If our acid-base balance, so that's the transport of hydrogen ions. So if we have too high of a pH of the blood, then we just are going to expel a bunch of hydrogen and allow that hydrogen to go into the urinary bladder. If we have too high of a pH, that means it's a basic or alkaline environment, then we're going to reabsorb those hydrogen ions to decrease the pH again. Waste products, so we typically are going to excrete large amounts of waste. Not many wastes are going to be reabsorbed. However, urea is a waste product that can be reabsorbed, and there's select other substances that will be reabsorbed that are considered wastes, but sometimes we need small amounts in the body. Protein conservation. So again, like I said, we want to keep the protein in the body, but the kidneys can play a role in protein conservation. And hormonal function. So urine is sterile, clear fluid that's slightly acidic pH. Discharge through the urethra. Micturition is urination. Average daily output is 500 to 1500 mils. And then there's anuria, oliguria, and polyuria. You do need to know what these definitions are, not only for this class, but also the qualifying exam. So anuria is basically the absence of urination. It's when you produce less than 100 mils of urine per day. Oliguria is less than 400 mils per day, so it's decreased urine output. Polyuria means you're peeing way too much. So poly, many, urea is talking about way too much urine production, and that would be greater than 2 liters per day. Polyuria can be seen in all different types of diabetes. So diabetes insipidus, diabetes mellitus, type 1, 2, gestational, so forth. The regulation of urine formation. So this is kind of a rudimentary drawing, but if you think about the kidneys, and inside of the kidneys, as I mentioned, there's this nephron system. And what happens here is you have blood vessels come into the kidney, so the afferent goes in, efferent goes out. And when it comes in, it's going to pass the blood through this ball, and this ball is called the glomerulus. Later in this lecture, we're going to talk about the glomerular filtration rate, and this is the location of the glomerulus. The glomerulus is extremely permeable, so it's a ball of capillaries that's thousands of times more permeable than your regular body capillaries. So if you were to compare any of the capillaries in your body to the glomerulus is a lot more permeable. Basically, anything that's smaller than a red blood cell has the potential to leak out. There's some large proteins that will be retained in the bloodstream, but a lot of substances are going to fall out of circulation here. And there's thousands and thousands of these in each one of your kidneys. When this stuff falls out of your bloodstream, it usually falls out down a concentration gradient. Waste products, like if there's excess waste products, those have to be actively transported out to make sure that it exceeds that normal concentration gradient, because we definitely want wastes to be removed from the blood. Once the stuff falls out, it's caught by this thing called a Bowman's capsule. The process of substances falling out of the blood is called filtration, or glomerulofiltration. Once they're caught by the Bowman's capsule, it's sent down this nephron tubule system that will reabsorb or re-suck up back into the body the items that we still need in the body. So what we need in the body would be our sugars, our amino acids, all of our helpful substances, and then what the brain deems is necessary for the function of the body. And there's hormonal regulation of this, which we will get into as we go through this lecture. But basically, the urinary system is then going to regulate all of our electrolytes, our fluid balance, and our acid-base balance in our body, just by selecting which substances to reabsorb or suck back into the body, suck back into the bloodstream, or which ones to allow to remain in the urine and pass out of the body. So we have the proximal tubule, and then there's the loop of Henle. There's a descending limb and an ascending limb of the loop of Henle. Then there's the distal convoluted tubule, and anything that still remains inside of the nephron is going to be dumped into the collecting duct. The collecting duct is then going to dump into the renal pelvis, which goes to the ureter, down to the urinary bladder, and eventually urinated out of the body through the urethra. The proximal tubule is the primary site for the reabsorption of all different types of nutrients. The majority of your glucose, your amino acids, and all of your electrolytes and fluids are going to be reabsorbed in the proximal tubule. The descending limb of the loop of Henle is going to be responsible for the reabsorption of water and getting rid of excess sodium and chloride ions. The ascending limb is permeable to sodium but not water, so this is going to allow for the reabsorption of the chloride, sodium, and not so much water. Once you get into the distal convoluted tubule, This is responsible for the reabsorption of ions and water. However, this is largely under hormonal control. So if you see a test question that says which component of the renal tubular system or renal nephron is largely under hormonal control, that would be the distal convoluted tubule. So hormones are going to regulate how much sodium is reabsorbed, how much water is reabsorbed in the distal tubule. And then the collecting duct allows for some reabsorption of water. This is another diagram. You can see that glomerulus, the Bowman's capsule, proximal, descending, ascending, distal, and collecting duct. When we look at the endocrine function, kidneys function in the synthesis, degradation, and as a target for hormones. So the kidneys produce renin, vitamin D, erythropoietin, thromboxanes, and prostaglandins. It helps to degrade insulin, aldosterone, and glucagon, and it serves as a target for aldosterone, ADH, and the parathyroid hormone. Aldosterone, you can make note of this function now. We will be going through these hormones again, but it's good to have these notes written down up front. Aldosterone targets the distal tubule and leads to an increase in the reabsorption of sodium. When you reabsorb sodium, water passively follows. So aldosterone primary function is to increase sodium reabsorption. Secondary function is, as a secondary effect of that, more water will be reabsorbed as well. ADH is anti-diuretic hormone. A diuretic is something that makes you lose water. Like if you think of diarrhea, you're losing an excess amount of water in the stool. Diuresis, the process of urination. So diuretic means to lose water from the body. So if we have anti-diuretic hormone, ADH, that means that you are doing the opposite of water loss. You are actually retaining water in the body. So anti-diuretic hormone acts on the distal convoluted tubule to increase water reabsorption. It causes more water to stay inside of the body. Parathyroid hormone. The function of the parathyroid hormone is to regulate calcium balance in the body. So when we have excess calcium, we want the calcium to be deposited into the bones. When we don't have enough calcium, we're going to actually break down the bone tissue to have the calcium levels in our body increase. Calcium's role in the body is massive. So it's not just to build strong bones. I know that's really been drilled in our heads from a young age, is you need to drink milk because of calcium. Calcium builds strong bones. That's not the only thing calcium does. Calcium plays a role in every muscle contraction, including the contractions of your skeletal muscles to help you breathe, the contraction of your heart muscle to help your heart beat and pump blood. So it has profound effects in the body, and it serves as a vital component to make a lot of these processes happen. So we're really dependent on having a steady state of calcium in the body. So if our calcium levels are low, parathyroid hormone is going to tell our nephron system to reabsorb more calcium. So don't lose calcium in the urine. We want to suck it back up into the body to maintain those blood calcium levels. Hormone synthesis, so erythropoietin, the cells close to the proximal tubule. The function of that is to, for red blood cell maturation, increase red blood cell in peripheries, and it's regulated by oxygen levels. Prostaglandins are secreted or synthesized throughout the kidney, have a diverse function: increased renal blood flow, sodium and water excretion, renin release, and they oppose vasoconstriction. Thromboxanes are synthesized throughout the kidney. Function is diverse, it's less characterized: inflammation and bronchoconstriction. Vitamin D, mitochondria of the renal cortex, sole site for the production of the active hormone, calcium, calcium balance, phosphate balance, and bone metabolism. Renin, juxtaglomerular cells, which are specialized nephrons, and that aids in the regulation of extracellular fluid volume and leads to the retention of sodium, which indirectly causes water retention. So let's follow through this diagram here. So if we have an increase in blood volume, let's start here. If we have a decrease in blood volume or blood pressure, if we decrease our blood volume or blood pressure, we can increase it again by adding more volume to the blood. And the primary thing that we can add into the blood to increase our blood pressure is water. So if we do see a decrease in blood volume or a decrease in blood pressure, we can stimulate the renin-angiotensin-aldosterone system, also known as RAS, R-A-A-S. RAS would increase the production of renin by the kidneys. So the kidneys are going to start producing renin. Renin is then going to stimulate the release of angiotensin 1. Angiotensin 1 is then converted to angiotensin 2. There's a hormone here called angiotensin converting enzyme, ACE. So angiotensin 1 gets converted to angiotensin 2 by that angiotensin converting enzyme, or ACE. From angiotensin 2, that stimulates the release of aldosterone. Aldosterone is going to increase sodium reabsorption, which increases the plasma sodium. That increases plasma osmolality, which increases water reabsorption, and the blood volume goes up. And this system is going to continue until we reach a normal blood pressure. Once the normal blood pressure is attained, this system shuts off. Now, I do want to mention a little bit about that ACE, angiotensin converting enzyme. So you may have heard of ACE inhibitors, and ACE inhibitors are used to regulate blood pressure. So if someone has high blood pressure, then we definitely don't want this system to keep going. So an ACE inhibitor blocks this ACE. It blocks the conversion of angiotensin 1 to angiotensin 2, so that aldosterone is never stimulated to be released, sodium reabsorption doesn't happen, and we don't keep flooding our bloodstream with more and more water. This will decrease our blood volume, thus decreasing our blood pressure. So an ACE inhibitor, that just gives you a little bit of insight as to where that takes place in this system. Okay, if we have an increase in osmolality or plasma osmolality, the hypothalamus is going to stimulate the release of ADH from the posterior pituitary. Antidiuretic hormone is going to directly increase water reabsorption. That's going to increase the plasma water and decrease plasma osmolality. If you remember, osmolality has to do with the concentration of stuff in the blood, the solid substances, ions, glucose, amino acids, the solids that are floating around in the bloodstream. If you have a high osmolality, that stuff needs to be diluted out. So you want more water to come into the bloodstream to spread out all of those nutrients. If we don't decrease the blood osmolality, that could lead to a decrease in blood flow or an increase in resistance of flow. That could increase the viscosity of the blood. So like if we had syrup trying to go through our bloodstream, it'd be really hard to move that through, and it would be really ineffective. But if we mixed up that syrup with a bunch of water, then obviously it's going to move a lot faster. And that's what this system is trying to do. When we have an increase in blood and plasma osmolality, that means that we have too much sludgy junk inside of the bloodstream. So we want to dilute all that out so blood freely flows through our bloodstream, and we can do that using antidiuretic hormone. So those are just a couple different hormonal regulatory mechanisms that you'd see in the kidney. Protein conservation. 180 liters of plasma, 70 grams per liter of protein filtered daily. 12,600 grams of protein. So less than 200 mg per protein excreted daily, less than 20 mg per day of albumin excreted. Most of it's reabsorbed in the proximal tubule. Non-serum proteins, TAM, horsefall, mucoprotein, is a high molecular weight protein that's the predominant protein that's found in urine. About 40 mg per day is excreted. And it is the predominant protein component of urinary casts. Proteinuria is an increased filter load, so increased glomerular permeability. We talked about the glomerulus and how substances fall out of the bloodstream at the location of the glomerulus. And it's the nephron tubule's job to suck back up the stuff that we still need in the body. But if we have an increase in glomerular permeability, that can be an issue. That means that more stuff is going to be lost in the urine. Increased concentration of freely filtered low molecular weight proteins. Overload proteinuria. So proteinuria is talking about too much protein in the urine. Decreased glomerular number. Decreased tubular reabsorptive capacity. So damage to the proximal tubule due to nephrotic drugs or other types of disorders could cause this. Decreased glomerular number and enzymuria. Postglomerular secretion or leakage. TAM, horsefall, mucoprotein, or hematuria. Hematuria is blood in the urine. Benign conditions, increased exercise. Glomerular is typically due to albumin, also known as albuminuria. Tubular, you'd see the appearance of low molecular weight proteins that are due to defective reabsorption by the proximal tubules. So typically those low molecular weight proteins would be reabsorbed, but if the proximal tubule isn't functioning properly, then they would be lost in the urine. May be observed alone or due to heavy metal poisoning, commonly associated with glomerular proteinuria. Overload is associated with hemoglobinuria, myoglobinuria, or Bence-Jones proteins. Bence-Jones proteins are prevalent in multiple myeloma. Post-renal, protein arising from urinary tract below the kidneys, caused by inflammation, bleeding, malignancy, diagnosed by microscopic examination of urinary sediment for cells. Nitrogenous waste, so non-protein nitrogen formed from the catabolism of protein and nucleic acids. So proteins are broken down to amino acids through the process of proteolysis. Lysis means to break apart. Proteo is referring to proteins. Then you have amino acids broken down into ammonia through the process of transamination or oxidative deamination. From ammonia, it's converted to urea through the urea cycle. Ammonia is highly toxic, and if this is allowed to accumulate in the body, it can cause detrimental effects on the entire body, especially encephalopathy or neurological disturbances. So the urea cycle is really important. We want to convert that ammonia to urea, the less toxic form. So urea, ammonia, creatinine, creatine, and uric acid. Creatine and creatinine. So creatine is converted to phosphocreatine through the enzyme creatine kinase. Phosphocreatine is a temporary store of available phosphates that are able to be used for energy production. So ADP, adenosine diphosphate, needs another phosphate to be converted to ATP, or adenosine triphosphate. ATP is an energy molecule that, when it wants to be energetic, it's going to lose a phosphate group and go back to ADP. In the muscles, we have creatine, and creatine can be phosphorylated. It can gather a phosphate group, and it can store that phosphate in the muscle tissue and in other various locations in the body. When we need energy for a short term, we can supply it with the phosphocreatine that is stored in the body. So phosphocreatine will then donate a phosphate to ADP to make it ATP. Spontaneously, some of the phosphocreatine can be converted to creatinine. Creatine is synthesized in the liver, kidneys, and pancreas. Creatine and creatine phosphate spontaneously and irreversibly convert to creatinine. The amount of creatinine produced each day depends on muscle mass and body weight. Creatinine is present in all body fluids, elevations in serum creatinine specific for renal disease. It's freely filtered by the glomerulus, and a small amount is secreted by the proximal tubule. It increases with increasing plasma creatinine. It decreases as plasma creatinine decreases. Serum creatinine concentration is maintained within narrow limits by the glomerular filtration. So we can use creatinine clearance to measure how well the glomerular filtration is happening. So how good our glomerulus is leaking out the excess nutrients can be determined by measuring creatinine. It's useful in assessing renal clearance, the volume of plasma from which substance is completely cleared by the kidneys per unit of time. So creatinine clearance usually exceeds GFR by a factor of 1.2 to 1.2 or 1.1 to 1.2 at clearance rates greater than 80 mils per minute due to tubular secretion. So creatinine clearance is measured as an indicator of glomerular filtration rate. Modified protocol uses cimetidine to inhibit tubular secretion of creatinine. Timed urine specimen and blood sample obtained. So the volume V of urine in milliliters, and the urine flow rate is calculated in mils per minute. Creatinine is measured mgs per deciliter or millimoles per liter in the urine and in the serum. The creatinine clearance is calculated. So the urine amount of creatinine, the volume of urine divided by the urine or the amount of creatinine in the serum. Urea accounts for 75% of non-protein nitrogen excreted. It's synthesized from amino nitrogen-derived ammonia by hepatocytes via the urea cycle. It's defective in cases of cirrhosis. Greater than 90% is excreted through the kidneys, and the remainder is excreted through the GI tract and skin. Clinical utility: plasma urea typically measured in conjunction with plasma creatinine. Serum urea nitrogen or blood urea nitrogen to creatinine ratio is used to determine pre-renal and post-renal causes of uremia. So if the ratio is greater than 20 to 1, with normal creatinine, it's interpreted as a pre-renal issue. So you have a decrease in renal perfusion, so not a lot of blood going to the kidneys. A high-protein diet. This is where those high-protein diet fads, like sometimes the keto diet or the Atkins diet, those can be detrimental to kidney function. It is highly recommended that if you're consuming excess protein, you need to also consume excess water so that your kidneys can still function properly. A GI bleed or increase in protein catabolism. With elevated creatinine, that would be considered post-renal. Mechanical obstruction of urine flow. If it's 10 to 1 to 20 to 1, it's normal, and if it's less than 10 to 1, you have a loss of renal function or a decreased GFR, tubular necrosis, decreased protein intake, or liver disease. Ammonia. The GI tract is the primary source of circulating ammonium. NH4 is ammonium. Ammonia is NH3. Derived from intestinal flora acting on the colon contents. Hydrolysis of glutamine in large and small intestine. Most is usually metabolized to urea in the hepatocytes or in the liver by the urea cycle on first pass through the liver. Exerts toxic effects on the central nervous system. It readily diffuses across the blood-brain barrier, and the rate of entry increases as plasma ammonium and pH increase. This is a diagram that shows ammonia metabolism, so you can take a look at this diagram. You can pause the video and look through it. Hyperammoniemia, inherited causes, defects in dibasic amino acid metabolism. Lysine and ornithine are typically associated with this. Ornithine transcarboxylase, arginase, or L-lysine dehydrogenase. Defects in metabolism of organic acids. So propionic acid, methylmalonic acid, isovaleric acid, propionyl-CoA carboxylase, or methylmalonyl-CoAse mutase. Acquired causes: advanced liver disease, severe or chronic liver failure, fulminant hepatitis or cirrhosis. Fulminant hepatitis, remember, is when it rapidly progresses to cirrhosis. So you get typically hepatitis B, and then it turns into fulminant where cirrhosis happens pretty rapidly. Renal failure. As blood urea nitrogen increases, it diffuses into the GI tract and converted to ammonia. Ray's syndrome, primary CNS disorder with minor hepatic dysfunction. Hepatic encephalopathy, excessive GI bleed, excess dietary protein, constipation, infections, drugs, electrolyte, or acid-base balance. Sample collection for ammonia, fasting sample. EDTA and heparin are acceptable anticoagulants. Serum ammonia values are significant but variably higher than corresponding plasma values. Place a specimen on ice immediately after collection. Centrifuge within 15 minutes of collection. Delays longer than 15 minutes between specimen collection and centrifugation can increase ammonia concentrations. This is extremely important to note the time of collection and when specimens were centrifuged. Perform the assay immediately. Frozen plasma is stable. And avoid hemolysis. Red blood cells contain 2 to 3 times ammonia as plasma. Sampling precautions. Significant sources of error are related to smoking in the laboratory atmosphere. Smoking, the patient must not smoke after midnight prior to collection. All patients should change into clean clothes or pajamas prior to sample collection. Heavy smokers should shower prior to sample collection. And the technologist collecting the specimen and performing the test should be a non-smoker. Laboratory atmosphere, so sample collection and testing should be performed in a special laboratory with limited access. Glassware should be chemically clean, soaked in solution of hypochlorite, and rinsed thoroughly with deionized water. Poor vein puncture technique increases ammonia levels 100 to 200 micrograms per liter. Any technique that allows the mixing of the sample with room air. You want to use a heparin lock, drawing up blood into a syringe and transferring the tube with anticoagulant. Partial filling of evacuated tube all can cause that. So any use of any of those things can cause an issue. Probing for the vein is also another issue. Metabolism of nitrogenous constituents. Uric acid, the major product of protein metabolism. Guanine, adenine, hypoxanthine, free bases, and nucleosides. Dietary purines converted to uric acid directly. The bulk of purines are excreted as uric acid, arise from endogenous nucleic acids, excreted through the GI tract and kidney. Renal handling is complex. Plasma urate is completely filtered at the glomerulus. Nearly all is reabsorbed in the proximal tubule. About half is secreted into the lumen of the distal portion of the proximal tubule. Further reabsorption in the distal tubule, and the net urinary excretion is 6 to 12% of the amount filtered. Hyperuricemia, too much uric acid, often asymptomatic, and it's detected with routine screening. Gout is above pH 5.7. It exists as a urate ion, which is more stable than uric acid. Below pH of 5.7, it exists as monosodium uric acid. It precipitates from solution, and it's responsible for clinical symptoms. Gouty arthritis, uric acid crystals in the joints and tissues surrounding joints. Elicit intense inflammatory response. Renal disease, so gouty nephropathy. Urate deposits in the renal parenchyma. Acute intratubular deposition of urate crystals. Urate nephrolithiasis, about 20% of gout patients, associated with hyperuricuria, excretion of persistent acidic urine, or both. Primary versus secondary gout. Primary is due to overproduction of purines or underexcretion of uric acid. Secondary gout can be due to high protein diet, excessive alcohol, malignancy, chemotherapy, or psoriasis. Treatment. Quantification of uric acid is important. Hyperuricemia with excretion of less than 600 mg per day. Uricosuric drugs blocks the carriers in the tubular cells responsible for uric acid reabsorption. Hyperuricemia with excretion of greater than 600 mg per day. Allopurinol. So overproduction resulting from increased synthesis of purine precursors, inborn errors of metabolism, Lesch-Nyhan syndrome, complete deficiency of hypoxanthine guanine phosphoryl transferase. It's a sex-linked disorder, manifests as mental retardation, abnormal muscle movements, and behavioral problems. Phosphoribosol pyrophosphatase synthetase superactivity is X-linked recessive, and glucose 6-phosphatase deficiency and overproduction and underexcretion of uric acid. Decreased renal excretion. So primary is idiopathic. We don't know what causes it. Secondary is caused by conditions associated with a decrease in glomerular filtration rate, an increase in renal reabsorption, or decrease in renal secretion. Chronic renal failure, drugs, so diuretic therapy, low-dose salicylates, lead poisoning, or metabolic acidosis, like ketosis or lactic acidosis. Not clinically important in and of itself. Associated with other conditions, increased uric acid excretion due to overmedication with uricosuric drugs, high-dose salicylate, renal tubular disorders, congenital, Fanconi syndrome, or secondary. Decreased uric acid production, overmedication with allopurinol, decreased dietary intake of proteins, severe liver disease, or xanthine oxidase deficiency, xanthinuria. Diagnostic tests of renal function. So creatinine is useful in determining the glomerular filtration rate or glomerular function. Urine total protein increased in renal absorption defects. Bence-Jones proteins aids in the diagnosis of multiple myeloma. Beta-2 microglobulin is associated with glomerular disease associated with diabetic nephropathy and renal transplant. Myoglobin can indicate acute renal failure. Microalbumin monitor renal function in diabetics. So the analysis of kidney function, non-protein nitrogenous compounds, urea, creatinine, ammonia, uric acid, circulating compared with those in the urine. Creatinine clearance. So we would measure it in the serum, then we'd measure it in the urine and see how much from the serum actually made it into the urine. Nephron or glomerular functions, glomerular filtration rate, renal clearance, renal blood flow, glomerular permeability or proteinuria, and osmolality. Secretory capacity of the endogenous or exogenous compounds, creatinine, urea, low molecular weight proteins, inulin, ioxhexol. Kidney reabsorptive capacity for water and electrolytes, urine concentrating ability. Renal failure, so uremia causes nausea, vomiting, lethargy, disorders of micturition, frequency, nocturia, retention, or dysuria, disorders of urine volume, anuria, oliguria, polyuria, alteration of urine composition, hematuria, proteinuria, bacteriuria, leukocyturia, or calculi. You can deduce what all of those mean based on the stems. So hemat is referring to blood, protein is referring to protein, bacteria is referring to bacteria, leuco is referring to leukocytes. Calculi refers to different types of stones. Pain, inconsistent. The CNS, profound drowsiness, seizure, coma, and death. Edema, hypoalbuminemia, salt and water retention, or electrolyte imbalances. Hyperkalemia, hyponatremia. Acute versus chronic renal failure. So acute is a sudden decline in renal function due to an insult on the kidneys. So hemolytic transfusion reactions, heavy metal poisoning, analgesia, toxicity, burns, cardiovascular failure, sudden blood loss. So a lot of different things can cause a sudden decrease in renal failure. Glomerular filtration rate drops to less than 10 mils per minute. The sequel consequence of electrolyte, acid base, and fluid imbalance. Patient history, renal biopsy, imaging of kidneys is important in the diagnosis. Laboratory diagnosis, you want to monitor electrolytes and fluid status. Blood urea nitrogen, creatinine increased rapidly. Azotemia. Metabolic acidosis becomes evident, and urinalysis. Pre-renal occurs before the blood reaches the kidney. Hypoxic results hypovoluemia, so all of a sudden you don't have a lot of blood volume. Septic or hemorrhagic shock if you bleed out or have septic shock. Burns, so burns can cause a drastic loss in fluids, and that's the number one greatest concern with burns is not infection or not inflammation or anything like that. It's really like the fluid loss. Or poor perfusion as a result of cardiac failure. Renal, occurring in the kidney due to acute tubular necrosis or other renal disease, glomerular nephritis, vasculitis, malignant nephrosclerosis, vascular obstruction. Direct damage due to renal tubules, hemolytic transfusion reaction, heavy metal poisoning, antifreeze ingestion, analgesic or aminoglycoside toxicity. Post-renal occurs after the urine leaves the kidney, and that's due to a lower urinary tract obstruction or ruptured bladder. Chronic renal failure is a progressive loss of functioning nephrons. Differential diagnosis by renal biopsy associated with electron microscopy and immunohistochemistry or PCR and in situ hybridization. There are 4 stages, and depending on which healthcare system you go to, they may stage this a bit differently. But in general, stage 1, renal function is diminished, blood urea nitrogen and creatinine are normal. Stage 2, mild renal insufficiency. Stage 3, frank renal failure with advancing anemia, acidosis, and other clinical and biochemical manifestations. Stage 4, uremia or overt renal failure, oliguria, anuria, edema, hypertension, congestive heart failure. Causes of chronic renal failure: primary glomerular disease, so like chronic glomerular nephritis, systemic lupus erythematosus, renal vascular disease, malignant hypertension, inflammatory disease, chronic pyelonephritis, tuberculosis, metabolic diseases associated with renal involvement, diabetes mellitus, gout, or amyloidosis, nephrotoxins, aminoglycosides, analgesic nephropathy, chronic heavy metal poisoning, obstructive hypertrophy, calculi or prostatic hypertrophy, congenital abnormalities like polycystic kidney disease, and miscellaneous, chronic radiation nephritis, Balkan nephropathy. Diabetic nephropathy develops in 45% of type 1 diabetics within 15 to 20 years of diagnosis. It's also noted in type 2, but in a lesser extent. Lesions are primarily glomerular. Kidneys become glucouric, polyuric, nocturia, caused by heavy demands on the kidney, nephromegaly, to diurese hyperosmotic urine. Microalbuminuria develops 10 to 15 years after diagnosis, progresses to macroproteinuria and steadily decreasing GFR, followed by hypertension. Chronic renal insufficiency, nephrotic syndrome may develop, prevented by tight control of blood glucose. Renal hypertension, caused by a decreased perfusion to all or part of the kidney. Chronic ischemia leads to nephron dysfunction, necrosis, resulting in changes in blood and body fluid volume, activates renin-angiotensin-aldosterone system. Manifests as persistent hypertension. Local tissue accumulation of sodium, and lab results include aldosterone, renin, sodium increase, urine potassium is high, and serum protein is low. Glomerular diseases: acute glomerular nephritis or acute nephrotic syndrome, large inflamed glomeruli with decreased capillary lumen. Laboratory findings: rapid onset of hematuria or proteinuria, albuminuria, rapid development of decreased GFR, anemia, increased BUN and serum creatinine, oliguria, sodium water retention, hypertension, edema, congestive heart failure. Numerous hyaline casts by urinalysis. Presence of red blood cells is highly suggestive, often associated with recent group A beta hemolytic strep infection. Immune complex mediated and IgA nephropathy is most common. Progresses to fulminant condition in some instances. Chronic glomerular nephritis is due to prolonged inflammation of the glomerulus, leads to the destruction of nephrons. Uremia is often the first clinical sign. Lab results indicate increased red blood cells, renal epithelial cells, increased proteinuria, oliguria progressing to anuria. Nephrotic syndrome, abnormally increased permeability of the basement membrane. Extreme proteinuria greater than 3.5 grams per d. Hypoalbuminuria. Decreased plasma onconic pressure leading to edema. Hyperlipidemia, lipiduria, oval fat bodies in the urine, and degenerated renal tubular cells with reabsorbed lipoproteins. Interstitial nephritis, affecting the tubulo-interstitium rather than the glomerulus. Generalized or localized chemical, bacterial, or immunological injuries. Pyelonephritis is most common interstitial nephritis caused by bacteria. And you can pause the video and go through this flowchart of the pathology of nephrotic syndrome. Tubular disease is secondary to reduced GFR. Primary tubular disorders, renal tubular acidosis. Proximal RTA is a result of decreased proximal tubular reabsorption of bicarbonate, causes hyperchloremic acidosis, increased water reabsorption. Manifests as low serum phosphorus uric acid, presence of glucose, proteinuria, amino acids, and glucose in the urine. Normal anion gap. Distal RTA, inability to create and maintain the usual pH differences between tubular fluid and the blood. Assessment for RTA, fractional bicarbonate excretion. Plasma and urine samples are collected. Creatinine and bicarbonate are measured. Fractional excretion of the bicarbonate is calculated from the ratio of urine to plasma creatinine, expressed as a percentage, so proximal RTA greater than 10 to 15%, distal RTA is less than 10%. Ammonium chloride loading test. Diagnosis of distal RTA, loading dose of ammonium chloride, 100 mg per kilogram body weight. Measure urine pH hourly for up to 8 hours. Normal urine pH is less than 5.5 in at least one sample. Distal RTA, there's a decrease, does not occur. Urine pH does not decrease, less than 6.5. Urinary tract infections. So pyelonephritis is an infection of the kidneys themselves. Cystitis is an infection of the urinary bladder, and it's diagnosed through colony count. Greater than 10.5 colonies per mil is diagnostic. Bacteriuria is positive nitrite by dipstick because bacteria have the ability to make nitrites and we do not. Hematuria, so blood in the urine. Pyuria, leukocytes as detected by leukocyte esterase in the dipstick. White blood cell casts are diagnostic for pyelonephritis. Renal epithelial cells, pyelonephritis, or transitional epithelial cells, cystitis. How the urine is obtained is extremely important in the diagnosis of urinary tract infections. So if the urine is caught by clean catch, that means that the patient is responsible for wiping themselves with a localized antiseptic or some type of wipe that they use. There's going to be a lot of bacteria or normal flora that's going to be present in that type of sample. Catheterized urine should essentially be sterile. So if we see any amount of bacterial growth in a catheter specimen or a suprapubic specimen. Suprapubic is when they take a needle through the outside of the pubic cavity through the bladder and take a syringe and actually use a needle to express the urine directly into the syringe. So that should also be sterile. You typically clean the skin before inserting the needle to get the suprapubic expulsion of urine, but those types of urine collection need to be noted on the laboratory report because there's different thresholds of what bacteria is kind of normal for different types of situations. Renal obstruction caused damage by two mechanisms. Gradually raise intratubular pressure until the nephrons necrose, resulting in chronic renal failure. Predispose the urinary tract to repeated infection. Located either in the proximal or distal urinary tract, upper urinary tract blockages, demonstration of dilated collecting duct above constricting lesion. lower tract blockages, presence of residual urine in the bladder after urination, slowness of voiding. Voiding is releasing urine from the body. Results in chronic renal damage. A variety of causes: neoplasia, prostate, bladder, lymph node, renal calculi or urethral strictures, and congenital deformities. So with patients that have prostate cancer, the prostate sits on the surface or the front side of the urinary bladder. In proximity to the urinary bladder. And when the prostate starts to expand, it actually puts pressure on the urinary bladder, and it can cause the inability of the urinary bladder to contract entirely. And if it doesn't contract entirely, some of the urine is left behind in the urinary bladder. And then that urine can flush back up into the kidneys anytime the patient moves or goes to urinate again, and the bladder constricts. That urine can flush back up into the kidneys, or it can back up into the kidneys, and that can cause major renal issues. Clinical findings follow a progressive course: decreased urine concentrating capacity, decreased metabolic acid excretion, decreased glomerular filtration rate, and decreased renal blood flow. Laboratory tests include urinalysis, urine culture, blood urea nitrogen, serum creatinine, and a complete blood cell count. Final diagnosis is based on radiographic techniques. Renal calculi, nephrolithiasis, formed by a combination and variety of crystallized substances in the organic matrix. There are different types of renal calculi that exist, and these can all be diagnosed by the shape of the crystals that we're seeing in the urine and the composition of what's in those crystals. So calcium oxalate, magnesium ammonium sulfate or styrvite, calcium phosphate, uric acid, and cysteine are the common types of renal calculi. This will be covered a bit more once you get into urinalysis and body fluids. Renal calculi: reduced urine flow rate related to decrease in fluid intake. Saturation of the urine with insoluble substances, and solubility is affected by pH. Excretion of excess quantities of insoluble substances. Primary risk factor is poor hydration, leading to more concentrated urine, predisposed to precipitation. Clinical symptoms: hematuria, urinary tract infection, abdominal pain, renal colic. Regulators of stone formation: so promoters, albumin globulin matrix substance A, and inhibitors: magnesium citrate, pyrophosphate, TAM horsefall, glycoprotein, and RNA. Predisposing factors: pre-urinary factors: female, sex, hot climate, stress, decreased fluid intake, protein-rich diet, immobilization. Urinary: an increased calcium, urate, oxalate, or pH, or decreased magnesium, volume, or citrate. Metabolic disorders: primary hyperparathyroidism, renal tubular acidosis type 1, hereditary hyperoxaluria, medullary sponge kidney, Cushing's disease, or milk alkali syndrome.